Hello and welcome to this talk. We're going to be going over induction and augmentation of labor. We're talking about a lot of the indications, again, definitions of abnormal and normal, and some of the medications and how these patients are managed. So as per usual, disclaimer, this is just for thinking about and education. It's not for managing patients or for treating yourself. So if you have any sort of problem, make sure you see a medical person to help deal with it. All right, and so induction of labor. The indications for this, as for lots of things in obstetrics, there's maternal, fetal placental, and fetal indications. So some of the very common ones that you should kind of run through in your head if you see that someone's undergoing induction and you're wondering why, could be post dates, so that's greater than 42 weeks, preeclampsia, IUGR, so intrauterine growth restriction of the fetus, non-reassuring fetal testing, for example, category 3 tracing, PPROM, so preterm, premature rupture of membranes. Other things like chorioamnionitis and placental abruption. All right, and there's some contraindications for doing induction of labor as well. So the overarching theme in the contraindications is that you think maybe a vaginal delivery is not safe here, because that's the goal of induction of labor, is to end up with a vaginal delivery. So complications, placenta previa, damage to the uterus, so a high-risk uterine scar, hysterotomy, incision through the uterus could make this not a good idea. Prior uterine rupture, transverse lie, concerning fetal heart tracing like category 3 tracing, active genital HSV infection, cord prolapse. Those are all things that would be contraindications to doing this. All right. So now, once you've decided that there is a valid indication, there's not a contraindication, then you have to move on to deciding, going about how are you going to start out doing this. And so the first thing you look at is predicting how successful you're going to be. So again, success in this case is defined as having a vaginal delivery as your outcome. And so the way to do that, as we talked about in prior lectures, was to look at the Bishop score. That takes a number of characteristics of the cervix and then add some modifications, and you come up with a number. And you take that number to look at your chance of success. So the key thing I think to remember there is 5. So less than 5 is a 50% chance of failure, so not ending up with a vaginal delivery. So in that case, you wouldn't want to go right ahead and start Pitocin, the oxytocin analog. You instead want to do cervical ripening. And so the mainstays for cervical ripening are prostaglandins, so Cervidil, misoprostol. Those are prostaglandins used for cervical ripening. And also things you could consider are amniotomy, it's making a hole in the amniotic sac and having some of the fluid leak out, mechanical dilation, if a person has a contraindication to using prostaglandins. This is something I'd be curious if anybody wanted to email me and explain a little bit better, someone more in the field, is that I've seen asthma and glaucoma as contraindications to using prostaglandins, and that I don't understand that from a pathophysiology standpoint. For example, prostaglandins are first line like treatment for glaucoma. Why would you not want to use a prostaglandin in a pregnant person to help them induce if they also had glaucoma? So that's something I'm curious about. But if there are contraindications using prostaglandins, you can use a Foley balloon. So that's you pass a balloon through the cervix, inflate it, and then put on gentle traction to start dilation. And membrane stripping is more of an office-based procedure, but it's essentially you insert a finger through the internal os, rotate it around, you detach the fetal membranes, and the idea is that this will hasten the onset of delivery. So many people are getting later on, like 39, 40 weeks, you can do membrane stripping with the hope that they'll go into labor sort of spontaneously at home. That's usually on people with a partially dilated cervix. All right, so the definition of labor, just as a review, that's regular uterine contractions that cause cervical change. And so some of these interventions that you may have already tried, let's say you have a low Bishop score of less than 5, and so you've decided we're going to do cervical ripening, we're going to use a prostaglandin. So you start that might start labor all by itself, as could make mechanical dilation. But the general pattern is that you would follow up those measures or initially start with Pitocin. Okay, so if the Bishop score was, for example, high, like an 8, maybe you would just start right ahead with Pitocin. You wouldn't do the ripening techniques. All right, so with Pitocin, it's good to know a little bit about one of the side effects. I think it's a tie-in with general sort of physiology knowledge. So Pitocin, oxytocin, where does that come from? It goes in the posterior pituitary along with vasopressin or ADH. And so this, as a way to remember that one of the side effects of oxytocin is hyponatremia. They both come from the posterior pituitary. ADH, as you know, puts in the aquaporins, and syndrome of inappropriate ADH, SIADH, is on the differential for euvolemic hyponatremia. So that's a tie in there you can help you remember. And then this whole topic in tachycystole, which we defined earlier, which I think that makes sense, right? You're giving something to help contractions. You can have too much contractions, greater than 5 in a 10-minute period. You have tachycystole, and then you'd want to stop or turn down on the Pitocin. All right, so this whole field of inductive labor has a little bit of controversy into it, because the number of people or percent of people having induced labor has been increasing, and people think there might be kind of some soft indications for inducing labor, and it's basically like people being sick of being pregnant. Maybe they're 38 weeks or something like that, and they don't want to be pregnant anymore, so they kind of get induced for sort of a soft reason. That's probably not the best thing to do. There should be sort of a real hard reason, as we went over in the indication, like being post-dates or having chorioamnionitis or IUGR, or some sort of real indication for doing this procedure, because it's not without its own complications. All right. So in general, somebody comes in, they have a good indication, they don't have a contraindication. Use the Bishop score, decide if they need to cervix be ripened or not. Then Pitocin starts, and then hopefully you end up with vaginal delivery at the end. All right. So moving on from induction of labor, so that's when starting out labor is not happening, to augmentation of labor. So that's labor has started on its own, but you're sort of helping it along. And so in here, the first part that I've kind of broken out is a prolonged latent part of labor. So remember, latent is the very first stage of labor, and this is an ill-defined time, because the starting point and the end point are hard to define. So when did the contractions really start? A lot of times it's not going to be all that clear of when these contractions started. And the end point, there's a historical Friedman data, 4 centimeters is the end point. Then there's also this more recent data suggesting 6 centimeters should be the end point. So if determining what this stage is when the time points is a little bit tricky, but we're going to use the cutoffs as a way to think about it as 20 hours for nulliparous and 14 hours for multiparous, and then just remembering that this isn't necessarily a protraction or a rest disorder, as we'll discuss later, and that would kind of make sense why the management is a little bit more laid back if there's not some other urgent indication for delivery. All right, so I think that using from when you think contraction started to 6 centimeters is a pretty reasonable approach. So what are some risk factors for having a prolonged latent phase? Unfavorable cervix would be the first one, and the second one would be a transverse or an OP positioning. So that's occiput posterior positioning. So remember, you have, just as a rough outline, you have pubic symphysis up here, anterior. You have the coccyx and the sacrum and the coccyx coming down here. Then you have the head, right? And so the normal situation is, this is the nose, so that you know which is the anterior and the posterior part. So that's the normal situation, right? The occiput is anterior, and it comes out like this. The fetus comes out like that. All right, so if you have it the opposite, you have occiput posterior or transverse, that's a problem. So this, as a review of this presentation here, you have head down. So the presentation is cephalic. Within cephalic, there's different types of cephalics. You can have vertex, as shown here, where you could put your hands in and you could feel the fontanelles. And then if it is vertex, you can decide the position. Is it occiput posterior, occiput anterior, transverse? How is it oriented? But you could also have cephalic and not vertex. You could have a face presentation or a brow presentation. All right. So those are some of the risks. And the treatment, assuming that there's not any big-time urgent need for delivery, like there's bad maternal preeclampsia or fetal heart rate doesn't look bad, a category 3 tracing or something like that, then the standard treatment is called therapeutic rest. And what that means is you give morphine. Hopefully the patient calms down, relaxes, maybe takes a little nap, and then you allow progress to happen, because you're not in a huge rush here. All right, and so then the person wakes up, or they start feeling contractions, and then they're in active labor, and that's what happens the majority of the time. And if that doesn't happen, you can consider oxytocin, giving Pitocin. And so the contraindications to remember before you give this drug is fetal malpresentation, where you don't want the uterus contracting hard when the fetus isn't in a good presentation, or prior damage to the uterus, or hysterotomy, for example. Incision in the uterus could weaken it, increase the chance of uterine rupture. So those are two contraindications I'd think about before giving oxytocin. And you can also sort of adjunct measures that sort of are more plus minus, or amniotomy, making a hole in the amniotic sac. So in general, the latent phase isn't being well tolerated. It's taking a very long time, greater than 20 hours, roughly in nulliparous, or 14 hours in multiparous. You can give morphine therapeutic rest to try and then follow that up with oxytocin. All right, so now we're moving on to the protraction and arrest disorders. And so the first group, or the first sort of category of this, is first stage of active. And so that could be defined as greater than 4 centimeters under the more traditional data, or greater than 6 centimeters under the newer data, and probably using 6 centimeters is the way to go. To decide if you're protracted or if you're going along normally, you can use the rates of dilation. So traditionally it's 1.5 centimeters in multiparous, or 1.2 in nulliparous. And I think that if you just remember 1, if it's greater than 1, they're making progress, they're probably doing well. I think that is a good general way to think about it. So if someone's greater than 6 centimeters and they're progressing at a rate of roughly 1 an hour, they're doing okay. All right, and so that would be protracted. So what about arrest? How would you define arrest? Okay, so arrest is you have no cervical change in 4 hours in the presence of adequate contractions, or you have no cervical change in 6 hours when you don't have adequate contractions. So I think this brings up the point of defining, so what is an adequate contraction? So when you're using the external monitor, the external tokometer and fetal heart rate monitor, you can see from those tracings that how frequent contractions are happening, like how long they're happening, but you don't know absolute number-wise what the contraction strength is. So to do that, you need to use an intrauterine pressure catheter, and you get a number result from that called Montevideo units, and greater than 200 of these units is considered to be adequate pressure generated by contractions. And so what this unit is a combination of pressure generation over time. And so they take the pressure generated during the contraction, they minus out the baseline pressure in the uterus, and they see how much pressure generated over a 10-minute period, and that comes out with these units. And so if it's greater than 200, that means that that adequate contractions are likely happening. All right, and so when you're thinking about when you're seeing a protraction or an arrest problem, then you should be thinking about sort of differential diagnosis and what could be causing this. And so you can use the 3 P's as a way to think about it. So that's the power of the uterine contractions, the passenger, the fetus, and the pelvis. And so I think the power one I'd probably emphasize here to help the cervix dilate, you need to have good contractions going on. So hypocontractile uterus, I think, should come up as something that you really think about. Passenger pelvis problems is getting at cephalopelvic disproportion, so that it's not quite as simple as just like something too big coming out of a hole too small. It has a lot to do with presentation and positioning as well. For example, OP position can make cephalopelvic disproportion more important. But if you want a simplified understanding of it, just think about the head and the pelvis aren't sized up enough for the head to get out. There's other rare causes like Bandl's ring, B-A-N-D-L-S, Bandl's ring, and so that's a uterus shaped kind of like this. It has this contracture in the middle, right there. It's contracted down, and as you can imagine, it's like almost like a rubber band around the uterus. It creates this hourglass shape, and you could see that it could be hard for the fetus to get through there, kind of get stuck there. And then analgesia, regional analgesia probably plays a role too in slowing this down. All right, so we've kind of talked about defining these things and sort of the risk factors of how you approach differential diagnosis. Remember that 3 P's, and really think about power in the first stage of active labor. And so the mainstay of treatment is oxytocin. Oxytocin is a medicine you give by an infusion, and so there's 3 parameters of this infusion. There's the initial amount you give. You're going to have an incremental increase, and then a time interval. So you could have a low dose oxytocin, for example, would be 1 milliunit per minute. That would be your initial. Then it could increase by some amount, let's say 1 milliunit per minute every 30 minutes. That'd be an example of a low dose. Or we could start at a higher dose, for example, starting at 6 milliunits per minute, increasing by some amount every half an hour or 45 minutes. I think it's beyond my scope or this talk really to get into the difference when you use different low dose or high dose. But that's how you'll see those things recorded and ordered. And when you're reporting back about for example, a progress note on labor, you should note what the oxytocin is at, and you're going to need to know those parameters. All right, so we've said this person's they're not progressing, they're protracted. We've started oxytocin, then what do? So because the definition of a labor arrest is 4 hours with no change, you're going to give them the oxytocin. You're going to make sure that you check within 4 hours to see if there's been progress. And if there's been no progress, then you would say they've moved from protracted into the arrested category. They might need to deliver with cesarean section. All right. Some problems with oxytocin. Tachysystole, I think we've mentioned that before. It's 5 contractions in 10 minutes. Too much contractions, you have to stop or turn down oxytocin. All right. So older, just as a side note, older definitions of labor arrest said 2 hours with no change in adequate contractions. But I think that using 4 hours is probably a good way to think about it. All right. So just by way of review, once you're protracted, you're not making progress, you can start oxytocin to help that. If you progress on to being arrested, so you're making no progress in 4 hours, then you might need to consider cesarean section. All right, and so now we're on to the second stage. So if you remember what that is, so now you're fully dilated and you're going from the time of being fully dilated to delivery. And so this the time periods here to remember are 2 and 3. So 2 hours nulliparous without regional analgesia, 3 with, and then 1 and 2 for multiparous. 1 hour, we should take 1 hour, or the maximum normal is 1 hour multiparous without regional analgesia, and 2 hours with. All right, and so that's the protraction definitions, and for arrest definitions, you just add an hour to everything. All right, so for nulliparous, 3 hours, 4 hours. Okay, so nulliparous with regional analgesia, if they haven't delivered in 4 hours, then they met the definition for an arrest. And the same thing with multiparous. Instead of 1 and 2, it becomes 2 and 3. All right, and so again, when you're thinking about etiology or what's causing this, you use your 3 Ps idea. So power, passenger, pelvis. And so power, could be a possibility, but in this stage, you're sort of fully dilated. You're trying to get through the baby, and come out. So you think about a little bit more about passenger and pelvis problems here as opposed to power. So cephalic pelvic disproportion, I'd say, is a bigger of an issue here, and that's something that's very hard to predict. There's things that would make you think about it. For example, fetal macrosomnia. Maybe mom is diabetic or something, at risk for that, or you have prior measurements that say that the fetus is likely very large. That make you more concerned. But it's often caused by presentation, position issue, and not an absolute cannot fit sort of thing. So when you're examining now, you're fully dilated, and so you're assuming you're in vertex. You can feel the bones on the fetal head. Okay, and so if there's severe molding, that's the bones pushing together, over suture lines. So if you feel the parietal bones pushing across the sagittal suture, that would say that there is a lot of pressure going on, and it's probably cephalopelvic disproportion. The baby's having a tough time squeezing through. So things you can do, you can try to manually correct. For example, if you have an occiput posterior position or transverse position, you can try to correct that. That might help with cephalopelvic disproportion, but there might not be anything that you can do. And if there's inadequate uterine contractions, again, you can use oxytocin, just like we talked about before. And then you can also, see now that we're in the second stage, consider operative delivery. Remember, that's using forceps or a vacuum. Okay, and if you can use that or not depends upon the station. All right, so the station is where is the presenting part of the fetus in relation to the ischial spines. All right, so if you're, the easy remember is if you're 0 or less, don't operative delivery using forceps or a vacuum isn't sort of on the table. But if you're 2+, then you can try, and if you're 1+, then you can consider it, but it's a little bit more risky. All right, so I guess the summary of treatment in the second stage is you have to think about etiology a little bit more. If uterine contractions are inadequate, you could think about Pitocin. If there's cephalopelvic disproportion, suspicion of that or evidence, for example, by palpating parietal bones across sagittal suture and feeling them overlap, then you could try to maybe change position, see if that could help. And also the big difference there between something you can't do in stage 1 is that if you're in the second stage and you have a station of +1 or +2, you consider an operative delivery, meaning with forceps or vacuums as opposed to necessarily needing cesarean section. All right, now we'll move on to the third stage of labor. This I wouldn't really consider this augmentation of labor, at least to my understanding of it. It's more of just part of active management of labor. But so it's definition, third stage of labor. You've delivered the baby and now you're delivering the placenta. It usually takes about 30 minutes. There's some risks that can happen in this stage of labor. So the biggest one is postpartum hemorrhage. Right? So the uterine atony, the uterine is not contracting down. You can think about it as being sort of tired from all this labor and delivery, and so you have bleeding. You also have uterine inversion and retained placenta. Those are the big risks during this third stage of labor. And the treatment or the general part of active management that you use is the first thing you go to is oxytocin. So it's not like if there's a problem you go to oxytocin. It's just use oxytocin and it helps the third stage of labor. You can also, as supplementary things, you do uterine massage and gentle cord traction. And if the placenta is not coming out with those, you can manually remove the placenta. All right, so I think that covers induction of labor and augmentation of labor. Thank you for watching. Visit the website for more, and check out 52kids.org and consider making a donation. Thanks again.